Hay que decirlo.
Well, technically we are.
I was going to say, it's the next 25 seconds on the stream.
What I was asking about was the topics, not the points. So the paper that we're that's
I got you. He has an answer. Bueno, vamos a empezar. Vamos a iniciar, tenemos unos minutos de retraso. Perdón, porque estábamos en una llamada de conferencia que hacemos toda la semana con el equipo de Harvard que nos apoya. Bueno, en primer lugar, darle las gracias a todos y a todas por estar aquí. Me imagino que estamos ya en live streaming, ¿verdad? Entonces, tenemos aquí a nuestro grupo de estudiantes, nuestra primera cohorte y segunda cohorte. Y también tenemos a un grupo de invitados de otras universidades, de UNIBE, están las personas de O&Med, que están siempre con nosotros acompañándonos, y que obviamente tiene que estar aquí porque su fundadora es la que va a presentar hoy. Vamos a darle un aplauso a su fundadora, que es la que va a presentar hoy. Y estamos muy contentos, doblemente, quizás triplemente contentos por lo que vamos a tener hoy. Primero porque la doctora Helena Chapman es una persona que hemos estado trabajando muy de cerca desde hace ya varios años. Tuve la potestad de tenerla antes de que ella llegara aquí al país, una persona que fue mi mentor en la Universidad de Miami, el doctor John Bayer. Me habló sobre la posibilidad de que la doctora Chapman viniera a República Dominicana a estudiar, y en ese momento yo regresaba y prácticamente me la traje en la maleta conmigo. Entonces le dije, sí, ven a estudiar aquí a República Dominicana, yo creo que aquí tú vas a aprender muchas cosas que no vas a aprender en otros lugares del mundo. El tiempo me dio la razón, ella vino aquí, terminó estudiando y se hizo médico. Ella, cuando vino aquí, ya tenía una maestría en salud pública. Entonces ella empezó como maestra en salud pública, vino y hizo medicina. Y después, cuando ella terminó su carrera, ella pensó que yo la había abandonado, pero yo no la abandoné. Yo le dije que viniera a hacer la pasantía conmigo y se fue para Sedimar conmigo a hacer la pasantía. Parece ser que le gustó porque entonces dijo, yo quiero hacer un PhD en salud global. Y entonces se fue a la Universidad de Florida y está terminando ya su PhD en salud global. Una persona que ha sido, vamos a decirlo así, forjadora de muchos grupos de trabajo, de muchas redes educativas, y que en particular yo he disfrutado mucho lo que ha sido la carrera de la doctora Charla. Me siento como que yo he estado en cada parte de aquellas cosas que ella ha hecho, y obviamente me siento también muy contento de que cuando ella haya venido aquí a hacer lo que se llama su Pilot Research Project, ella haya decidido venir al Centro de Investigación en Salud Global y Biotecnología que tenemos en nuestra Escuela de Medicina. Aparte de todo eso, ella está haciendo la educación de la doctora Chapman, de un Bachelor of Science in Biology, University of Florida, un Master in Public Health Epidemiology, University of Florida, Doctor of Medicine, UNIBE, pasantía de ley en Sedimat, que ya lo dijimos, y es un estudiante, un current student, un PhD candidate, tiene su segundo año ya de PhD en el Department of Environmental and Global Health, de University of Florida. tiene mucha experiencia en la parte académica de investigación, a pesar de que ella ha sido muy tímida poniendo algunas cosas aquí. Es Research Assistant, Stroke Research del 2003 al 2005, Veteran Administration Medical Center, Rehabilitation Outcome Research Center en Gainesville, Florida, profesora de UNIBE, 2012-2013 en Preventive Medicine, Research Assistant en TB Research de 2013 al presente, en the Southeastern National Tuberculosis Center, UF, Gainesville, Florida. Ha tenido experiencia de investigación en dengue fever, tanto en Cuba como en República Dominicana, como en Puerto Rico, en tuberculosis también en la República Dominicana. Es una persona que ha trabajado mucho en lo que es tuberculosis, tanto la parte cualitativa como cuantitativa. Mucho que decir de la doctora Chapman, pero yo creo que lo vamos a dejar ahí porque si no, no vamos a pasar la tarde entera hablando de ella. Ella va a hablar en inglés. Entiendo que algunos de ustedes se van a poner muy contentos con eso, Armando. Entonces, pero sus vistas fijas están en español, ¿ok? Recuérdense que estas son actividades extracurriculares que pueden ser tanto en español como en inglés. Las hacemos la gran mayoría de veces en español, porque aunque nuestra escuela tiene un currículum de 6 años en inglés, también tiene que el estudiante estar expuesto a español porque es lo que va a hablar con los pacientes y con las personas de la comunidad. Please join me to give a big applause to Dr. Helena Chapman.
Thank you so much for the wonderful introduction. I am still suffering a little bit from a cold that I had last week, so I hope you all bear with me. And this is going to be a presentation that I'm actually very proud of because it's something that I'm dedicating the next 4 years of my life to. But first, I did want to give a shout out to the O&M family who is here in this room, mostly because they come from different universities and different towns, especially La Vega. And at the same time, our IFMSA family, because we have friends from Africa who are joining with us via live stream, Victor and many of my other colleagues. So that is what's making this presentation even more special, because not only are we looking here in the Dominican Republic and in the Americas region, but also across the world. One Health is something that maybe you have all heard of, maybe not. The concept is not new, but the coined term is. So at first, one of the things that we've all been talking about a lot recently is globalization, especially with the 2 endemic diseases that we've been seeing more frequently in this area. I then am going to talk a little bit about what exactly is One Health as a definition, with a couple of case studies and a revision of a case. And then basically how we all, as medical students in formation as well as medical residents, can be able to apply this concept as we go throughout our careers. And finally, what some of the challenges we might face en route. So first of all, a little bit about globalization. Obviously, this is a big term we've all seen recently with the endemics, as well as just even climate change with a lot of the the politics that have been going on in the US as well as across the world related to climate. But this is something for us to all consider, not just as the Dominican Republic. We are one island across the Caribbean. As you can see, we all know very well where this is, but many of our colleagues who collaborate with us in other countries may not know exactly where we lie and how close we lie to other countries. Obviously, this map may not have meant much until chikungunya came into play, but that's something to consider as far as geography. But why should we even look at a map? In medical school, we should be learning about community and social medicine, which is what O&M medical school is making a big form of the medical formation early on. But why should we actually be looking at a map? Think about the different concepts when we look at this. Although a small country, there's a lot of diversity when we look at geography, climate, urban, rural regions, even populations that are vulnerable or at risk for different diseases across the whole country. And then the educational system as well as the health system might be different. So these are things to consider when we look at a map and how we can play that into a role when we are actually implementing our own programs, whether it's in our clinic or in a public health setting. But the actual impact of globalization is diverse and far from what I'm going to mention. We have different emerging diseases. Obviously, the two that are of most importance currently are chikungunya and Ebola, which have most of us a little concerned. But also there are different things such as climate change, looking at urbanization. So in urbanization in itself, we have individuals from different parts of different countries, not just the Dominican Republic, that go to urban settings, whether it's for employment, whether it's for family, whether it's to study. That creates different types of conditions, such as potential overcrowding in different areas, which is associated with many different social conditions and risk factors. Deforestation, we have different agriculture here in this country, as well as when we think a lot about the Amazon and some of the deforestation that produces new environments for vectors, for example, as well as the transmission of diseases. And a little bit further, I'm going to show a map about vector distribution, but over the years, if anyone has been following the difference of dengue fever across the world, you will see that the geographic distribution of just Aedes aegypti in itself is frankly disturbing because it is now opening and creating much more people at risk for diseases such as dengue fever. International travel is something that has been a lot more in the media, which I'll talk about in a little bit, as well as just looking at different political conflicts that are also a cause for different migrations or different settings to refugee status, not just considering disaster settings, but also considering current conflicts, whether political or religious. Another thing that is currently in the news is e-health or e-salud. This is electronic health, which is something that's a lot being promoted, especially by the World Health Organization. But e-health is composed of many different areas, such as iHealth, which is information health, and M-health, which is mobile technology health, which information health is the idea of what we all as future physicians need to know, how our patients are going to understand the diseases that we're going to be presenting to them and be watching for risk factors. For example, in the clinic setting, your patients are going to be checking WebMD and possibly Medline and the NIH areas and come and actually present their diagnosis to you when you're in the clinic. They may be one of the differential diagnoses that might be considered, but they're very certain that they have this disease. So you need to be up to date on basically all this information of where your patients may be receiving their health information. At the same time, mHealth is mobile technology, and that is something that is being used a lot more frequently in diseases of long-term management, for example, HIV/AIDS or tuberculosis, where they often give a mini message to the patient who is coming with these, in order to remind them to take their medication. That's being used in different, and I think it's also being used currently in some of the diabetes work. And that's something with mobile technology or providing cell phones to individuals. And even in areas, in very remote areas, individuals have cell phones, so this is a technology that could be potential beneficially. So why, when we look at climate changes, and I'm getting to this because One Health is a component, it incorporates the environment into our consideration of disease. But we look at different severe patterns of climate that we've had, whether it's drastic downpours, it's severe drought as well. And we've been in a drought here, and all of a sudden there's a downpour, so it creates different environmental conditions. At the same time, the variation of rain as well as temperature. So a lot of times we're seeing now that actually the winters are much more warmer than they were in some areas of the world, but much more colder in summer areas. So it causes different, risk factors for your patient as well in that area. As economically, it also is very important because when we look at migration from a rural to an urban setting, now it causes different risk factors for social settings. So when you look at overcrowding and what kind of conditions does that come through in developing as well as developed nations. Then you have also domestic and international travel. So right now we've been looking at the trace, which we're going to talk a little bit about chikungunya as far as the tracing, but looking at international travel, which is the difference from one person traveling and coming back sick versus another person coming back and actually being part of the index case for a local transmission of the disease. The same thing is the utilizing of the land. Land utilization has changed over the years as well, especially with deforestation. So areas that were previously with forests are now used for planting or possibly swamp areas, which is now creating a lot more opportunity for vectors such as malaria to be prevalent in different areas of the world. And finally, which is something that is an unfortunate case for the disease that I'm currently studying, tuberculosis, the erroneous utilization of antibiotics in treatment or the inadequate use compiled with also the idea of individuals abandoning treatment is something that also can create emerging disease and also resistance. So I'm sure in some of your classes you've already talked about something about Aedes aegypti to some extent, or mosquito geographies. In the 1970s, that is when it was more or less remerging, because prior to those 2 decades they were using a lot of pesticides for vector control, which were fairly significant. And then right in about the 1970s, that was when there was a reinfestation of Aedes aegypti. And you can see just in these 30 years, and even more so, now there is Aedes aegypti back again in significant numbers. And Aedes aegypti is a vector for many different diseases, including yellow fever and dengue fever, and now obviously chikungunya. And the deaths from vector-borne disease are significant as well. So it's not something that we can just ignore in itself, being that maybe dengue fever produces more morbidity than mortality in some cases. But there are other vector-borne diseases that do cause fatalities. But really, what is the impact when we look at the environment as far as the increase in temperatures? So this can also affect both the disease as well as the vector. So not only are the life cycles of vectors potentially increase in itself to be able to propagate the disease more, but also the incubation period. So there are different things to consider, because now there's more risk factor for being able to have increased disease propagation within a community or a country or region. We all know this triangle very well, I'm sure. The epidemiologic triangle, it should be ingrained in your head. We're looking at this from different levels, but my angle for this presentation with the One Health is looking specifically at the environmental health angle, which is the right bottom corner, and looking at how the etiological agent, which we can take, for example, dengue fever, chikungunya, the virus is going to be the etiologic agent, and you're looking at the susceptible host, which in this case, we're talking about a human. In other cases, you can also talk about a pig or different areas, but between the etiological agent and the host, you have where the vector comes in, which if the vector plays a role, which in this case, the 2 diseases I mentioned, it would be the mosquito. This is important to take into consideration in all of your medical formation, because this is pretty basic, but it's to be able to keep everything on how things are connected. And that's the point of this presentation, because in One Health, everything is connected. Some of the impact of international travel is significant, whether it's by airplane, whether it's by boat, whether it's by travel, whether it's going along with horses, and as far as migrations, you have to think at all the different facets. In particular, there's something, I'm not sure if you've heard of airport malaria. No. The Anopheles, it's an Anopheles species, likes to hitchhike. So we'll sometimes hitchhike with some cargo, and then there'll be cases of airport malaria, which will be the areas right around the airport actually have some malaria cases, and it's due to Anopheles being brought into an area. Sometimes those mosquitoes will be able to invade the society and have a biological invasion and be there to stay. If they are not to that area, it'll come to a naive population, and sometimes it will just be a case and coming, and that's it. But that's to consider, as these are some of the areas that to consider. This is something called mass medicine, if I'm not mistaken, but it's some different area of medicine which has come across, and we've had different presentations at our university about it. But the Hajj and Umrah are two different areas of religious migration to Mecca, Saudi Arabia, where there's a significant number of individuals in this pilgrimage that they do at different times. These are the specific times, but they have opened it up over the years to different months. But the significant time is in October for the Hajj, for example, and you have a significant number of people in one area. So one thing that we've noticed in 2012 is when there was an index case of something which we now call MERS, the Middle East Respiratory Syndrome, a coronavirus, similar to what we look at, for example, SARS, but this one is much more fatal, which we have seen with some of the cases. But in this one, which I want you all to think about, is this disease occurred. It took them a little while to figure out through an epidemiologic outbreak what exactly happened, and now you have potential 3 million individuals in one area, close confinement, as you can see from this picture. Those are all people. And so anything, in particular, anything very contagious, especially the respiratory system, can be transmitted. So that was something that was discussed recently. Not only can you potentially have different diseases that are of the respiratory transmission, but also dehydration or any sort of injuries being around a lot of people. That's something to consider as well. I don't know if you've been reading recently, but they've been trying to figure out what is the mode of transmission. And immediately through this epidemiologic look, they were looking at, is it a camel? Is it a bat? And start taking blood samples to be able to see if where the actual transmission came from, because it was actually unknown. Some of the professional organizations that you may have heard of, the American Public Health Association, if I'm not mistaken, is the largest in the world. It has people of different disciplines within the health domain, so whether laboratory, clinical, fieldwork biologists. But look at just their themes in the last presentation. So Think Global, Act Local was one, and the other one was health. The one for, excuse me, it's for this year, is healthography, how where you live affects your health and well-being. So it's all integrated, which is where you can see is where this presentation is going. And for the International Federation of Medical Students Associations, which is where O&Med plays a part of that, is Health Beyond 2015 Get Involved, which if any of you have heard of the post-2015 at all, maybe. That has to do with the Millennium Development Goals that we have. They're across the world. Obviously, they're targeted for those countries of increased need, but if you've read those 8 goals, one of them includes some infectious diseases that may be endemic, such as malaria, tuberculosis, HIV, AIDS. So these professional organizations are playing a role that we need to think not just locally, but also globally at our health. So giving that little bit background of what exactly, so how environmental health is of somewhat importance, because it is not a main theme in medical school. I learned about it for one class when I was in my master's, and I'm learning about it now, obviously, because that's my specialty. But it's something to consider when you're relating to One Health. And what exactly is One Health? I'm in a program which is the only PhD program in the world currently for concentration in One Health, which is in the Department of Environmental and Global Health. These are the first graduates of the master's program. As you can see on their graduation caps, they are very excited that they are the first ones graduating with a master's of health science in One Health. They did their capstone projects in different areas. One did them in mosquitoes, one did them in more health outreach, and the other one did it also with mosquitoes. It's kind of a big common area. But that's something to consider. When we look exactly at what is health, health, as we know from the World Health Organization, is that it is a state of complete physical, mental, and social well-being, not just the absence of disease. I'm sure you have this definition ingrained in your head, especially the O&M students. That's something to consider as well with what exactly is health and how do we define it and how do we include One Health into that. But when we look at health from that angle, are we looking at health? Does health equal not having disease? Is that this antithesis? And that's something to consider when we're looking at what exactly, how do we define health, because your patient is going to define health in a different way as well. So the concept of One Health is not new, as I had mentioned. It does require different collaborations in order to be able to solve complex health problems that involve the environment, animal health, and human health. And that's being able to help. You've all heard the word zoonoses, and that's very in term with One Health, because now you have a different potential focus or risk factor, which could be something from the animal, which we'll see in some of the clinical cases. But it is having better control and prevention of some of these infectious diseases that are emerging, as well as potentially zoonotic. Up to 75% of emerging diseases are actually zoonoses. So this is of importance. Even if you are studying medicine and don't plan to be a veterinarian, it is important to consider, because your patients will have exposure to animals, and if you don't ask, you will never know. This is a concept that actually was brought up by our department chair, Dr. Gregory Gray, and he was making this different graphic to bring to idea the complexity of what is zoonotic diseases, as well, and how you can partner, and how you need to look at different risk factors between how all three of these are together. The middle component being that One Health with the yellow. So when you look at human medicine, which if you all know from the blue, right? Looking at not just clinical medicine, but also looking at even improving health, which is our whole idea of primary prevention. So looking at, whether it's from breastfeeding, or whether it's looking at, the genomic sequencing of diseases, to even just healthy lifestyles to improve quality of life, such as riding your bicycle, physical exercise, and also getting those vaccinations that are of importance. So not just those individuals who have no risk factors or no predisposing risk factors, and those who do. At the same time, when you look in the green, you're looking at the environment. So I did talk about that already, but in addition to that, since it's a very vast topic, not only do you have vectors and you have environmental conditions, but you also have, for example, fish. How many people here eat fish? So a significant amount. I had fish twice yesterday. And what happens if the health of the fish is not appropriate and now you're eating it? Or what if the waters are not clean? Or what if the waters, there was different medications that were thrown into the water, and now these fish are being around those medications? So that has a lot to do with human health, and even the quality of water. And then in the brown component is animal health. So how many people have seen a rooster walking around in the city? Yes, here especially. So, and that's, one area, but there's also, you look at cows and horses. So when you have your patient in front of you, you need to know what is their condition to be able to follow them appropriately and be able to advise accordingly. You'll see that from one of the clinical cases, but these are different animals that could potentially be pathogens, can have pathogens, and they may not show symptoms, or such as bats. Bats are carriers for many diseases, and actually can transmit them. Transmit them indirectly to other animals, and those animals can transmit it to humans. But what exactly is my role? So there is a relationship, an interaction between human health, animal health, and the environment, and that is something that should not be underplayed at any time. But there is a way that we can collaborate between disciplines to be able to find the best solution to be able to promote and to improve health for the human species, the animal species, as well as for our improved environment. So that includes, Felipe Diaz is a demographer. You would think, well, why would I want to collaborate with a demographer, right, Felipe? Exactly, but he has a lot of knowledge that we can all learn from. But then why would a social scientist be interested in clinical medicine? Well, because they have a different aspect. So you're looking at all the different areas in biological sciences. I collaborate right now on a One Health newsletter, and the individuals on that are not just, I'm the only with the clinical background, but there are others who have an ecology background and ecosystems and veterinarian medicine. So there are different areas to think about as far as these collaborations. So for example, this is from an undisclosed location, but where exactly does our patient live? You're all going, some of you are early in the formation and you haven't gotten there, but you've gotten to some of these questions on how you can do a physical exam, although may not have done a physical exam. But where does your patient live? And what would you actually include? If you did not know this and your patient comes, what would you ask? And would it actually be different if you knew this is where your patient lived? Would you add anything else to your medical, your questions to medical history? What are some of the things you can see in this picture that are a little frightening? Say the letter. Mm-hmm. So,
something that contaminated the pig, and they're going to be using that pig for a source of food, so they're going to be intaking that contaminated air, and then they're going to be mixing all that stuff into themselves. So that's a big hazard.
wonderful. So the quality of the drinking water, which they tell you should not drink from the tap, right? But I've seen many people drink from the tap, and I'm sure as many of you all. Yep. Something?
Yeah, I was going to say not only that, but also if any of the kids playing, I don't see them with shoes and they can cut their feet, and if they go play to the river with a cut, you can then have infections and some of the things in that specific area. And you also see that they actually do not live in a specific place that has like a lot of protection. So when it rains and everything, they're vulnerable to many other factors.
Wonderful. Thank you. Anyone else? Catherine.
Well, unless if they have a common latrina for the two families, or just for one, or for the community.
And Catherine spent, her and Maria were both at an UNAP, one of the attention primary centers in very small towns. So I'm sure they know a lot of what could be those questions. So thank you. Anyone else? How about one more?
Trash, and the water's also stagnant. So.
Wonderful. Great. No one has mentioned that there are two pigs, or one pig, right there.
That's what she meant.
I mean the water, but like I was focusing on the water. Yes. And what about the child carrying the baby?
Yeah.
So those are things to consider. Great contribution. Thank you. Another thing to think about are some of the natural disasters. So these are just only some of the disasters. There are obviously different ones. They all bring different potential injuries, pathogens, just different areas to review when you have this. For example, there will be more potential impact injuries when you have an earthquake versus if you have flooding those areas. So those are different things to consider. And that has actually been written a lot about in disaster medicine, which is a particular area of medicine. And here in 2007, some of us had an opportunity to participate in some of the disaster relief efforts for Tropical Storm Noel, which happened here around Halloween of 2007, and a week later, Olga happened on the northern coast, literally a week later. Both areas had significant flooding, as you can see. And right after this, as you can imagine, there were significant epidemics of leptospirosis and of dengue fever, in addition to gastrointestinal diseases and different kind of dermatologic lesions such as fungus. So to go into this first, it's a case study of something that has been written about in the literature. I actually study with one of the individuals who was on this case, which is why I know a significant amount, more than probably I want to know about this case, because this is the case, and I'm sure if you've heard or seen the movie Contagion, yes, maybe, this will be a reflection because this is actually the condition that Contagion was made off of. So in September 1998 to May 1999, there was an epidemic of encephalitis and respiratory diseases between male adults in Malaysia. So we're looking at this area of Southeast Asia. You got the map. Things are very, very close, correct? You can see not only do you have Malaysia, you have Brunei, and then obviously Indonesia, and Borneo and Sumatra. So different areas that are together. As you can imagine, they probably share trade. They have different people who are immigrating back and forth, whether daily or whether permanently. So I'm going to give you some basic descriptions of human cases. So they had a clinical presentation of high fever, headache, myalgia, vomit, dizziness, non-productive cough, and encephalitis. There were 282 cases and 105 fatalities. Later, 26 individuals then followed with a pathologic sequela and passed away. So what is going through your head right now? We just learned the epidemiologic summary of what had happened in this time span. What are some of the things that are going through your head, or some questions that you would want to ask me? Mm-hmm.
I mean, the contagion, it was done between different places. I want to know exactly, I want to find out what it's, how it's transmission process. Whether it can be airborne, whether it has to be through fluids, or anything like that, to see how far it could probably reach and how fast at the same time.
That's a very good question. That should be one of the first things on the top of our head. I'm not going to give you that answer quite yet. However, that is the search that we should have. What other questions are we thinking about? So don't tell me I give you this and you have no other questions for me. I've given you the clinical presentation, the number of people who were affected, the number of people who died.
With the 26 people that died, that had secondary causes of death, I would want to know what the difference in their treatment process after they were already diagnosed and passed through, what their difference in treatment was that caused them to die and not do other 183 people that were there, or I'm sorry, 177 people that were there.
Good. Okay, I'm going to keep going. But those are some things to start thinking about. That is definitely the first things to have in your head as far as clinical relation. So let me go one step further and see what you have to say. So the pigs got sick. So they had an acute fever, respiratory signs, neurological signs, the pigs, right? You don't have to diagnose them. Someone else was diagnosing this, obviously. And that some died asymptomatically or had some nasal bleeding. Some of them had abortions, those that were pregnant, but there was very low mortality, so below 5%. Anything passing your head right now? Mm-hmm. A little bit louder.
Weren't they quarantining these pigs after this whole situation? I mean, like, it doesn't matter if it's less than 5%. I mean, the outbreak is there. So what was their proper protocol towards this type of situation? That's
Very good question. Very good. Go ahead.
Yeah, I mean, I would have to search more about the correlationships to make sure that the symptoms kept matching up. But the fact that the mortality rate is so much lower for the pigs than for the humans, what mechanism in the human's body or in the pig's body keeps them from getting having fatalities as high as in humans? Considering our anatomy is so close to that of pigs, what is the exact mechanism? I feel like it'd be easier to find that out than maybe some other pathways of the.
Very good. Disease pathogenesis. And you have one. Okay. Good. Some good different suggestions, and that is something definitely to consider. Why was there so much less mortality in this group, more morbidity, right? Because they were sick. But no one asked how the pigs got sick.
I was not going to ask that, but I was going to make the comparisons that both humans and pigs got sick. So I don't know if the pigs are actually carriers or just symptomatic as well as humans. So I would like to know if the pigs are also being the carriers of the disease, not just being
I was also going to ask in the part before that, and now that I see this actually come up more the question if actually the people who died, the 26 persons who died, had a specific relationship on the area they live or like a specific characteristics, and if they were actually farmers that had the pigs or something like that, that actually maybe induced that specific disease.
Exactly. So if they had different risk factors, or they had different things in common, because obviously you're not going to know it's a risk factor at the beginning. You're going to do the outbreak investigation to figure out exactly what are those things in common. Do you have another thing? Okay. Great contribution. Thank you. That is definitely something to consider. So back to what was already suggested is how is this actually being transmitted to the human? And what is the connection, or what is the arrow? Is it a double arrow between humans and pigs? Or is there actually something else involved that we don't know? So it can be different. So that's when you have to start thinking. This is not something you figure out overnight. You have to do an outbreak investigation. The answer, obviously some of you have seen Contagion and you might have seen the answer, but the pigs actually had contact with the feces of fruit bats. So when the bats were living in the field, the pigs were infected. The pigs would sneeze and bring those aerosol particles, and that's what would affect the human. But is anyone wondering how the bats got there? Why did this not start beforehand? Well, casually, the pig farmers of Malaysia had planted mango trees in order to improve some of their income. And for such reason, the mangoes, of course, are sweet and attracted the fruit bats. So you can kind of see how this connection is going, right? This is not something that was done overnight, but this is something that was trying, because the bats apparently in this situation are carriers, right? Asymptomatic. Mm-hmm.
You can also see that it was because the human they knew that the fruit would attract the bats, they could have avoided with the knowledge. So we want to get that knowledge to prevent it to avoid.
Exactly. Thank you. So that's something to consider, but that's from a start to finish that was a little bit more expedited because this is an epidemic and they didn't want other individuals to get sick. But how many of you have asked a patient or in your mock interviews what the occupation of your patient is? And if so, which should be, what do you do? Well, what is their exposure to animals? Are they around a lot of roosters? Do they pass by a rooster once a day? Is a rooster live with them? There's a case that was in Florida that someone had actually was living with an armadillo, like actually slept in the same bed with an armadillo. And we can think of certain diseases with armadillos. Of course, she did not get sick, but it's something to consider with. So we need to ask about those. So this is called Nipah virus. Just how they had noted that the transmission in this scenario was through aerosol particles. And then they had also thought that potentially through direct contact with infected pigs, whether nasal secretions or tissues. At the same time, from the pig, they were getting the transmission from the fruit bat. So that's looking at two different ways. But the actual impact of this virus to the industry as well as to human health are significant. So looking at the impact of the industry, not only did they lose almost 1 million pigs from about 900 farms, which is in dollars, almost 60 million US dollars, the loss of 36,000 jobs and the loss of potential exportation of about 120 million US. If you remember the map that I just showed you before, which I'm not too familiar with Southeast Asia geography, but you can look at a map and you can find out, but they were actually selling, which is why if you look at the impact to the human health, how did Singapore and Indonesia become involved? Well, they're selling their pigs, their livestock. So they didn't know they were sick, the pigs aren't sick, and they can sell them as they would normally do to the countries that are nearby, and they would put the pigs on a truck and go over. So that's why you have cases that are nearby. So something to think, but there was no new cases post-epidemic, so they were able to control it. So it's one thing to consider, not just we're looking at human health, but also economy, because when someone does not have enough money, they won't be able to get enough food that goes on the whole social that we've all been looking at social medicine, right? The second study is very similar to what I just presented, but has a different twist. So in January 2005, a little bit after this other epidemic, there was another epidemic of encephalitis and respiratory disease between male adults in Bangladesh. Here's some of your geography, right? We have it bordering between a variety of different countries. A little bit of a cultural context is that between the months of November and April, they collect palm date sap. You can see how this contraption is. There's a little bucket that the individual has because they're collecting sap. They drill a hole into the tree I have not seen this. I've just read about it, okay? They drill holes, and then the sap comes out, and you can either drink it crude, or you can actually cook it in to make molasses. It's what they normally make. So some of the human data are from 3 different areas in Bangladesh, and there were 2 different studies that were done afterward. One of them was a case control study with 1 case and 3 controls. The odds ratio suggested that it was actually the ingestion of this palm date sap. In that instance, what they actually found was is the pig or the bat involved in this case, which it's still Nipah virus, but they actually found that that during the night when someone is actually collecting this date palm sap, that there are fruit bats that are coming and actually licking the sap. And so someone would drink it crude and would become sick with one of those cases. A cohort study was done where the relative risk was actually shown this transmission, that where there was actually human-to-human transmission with an infected case. And it was shown with some of the physicians who were taking care of the cases. So now we're looking at 2 different modes of transmission in addition to the one we just described of the same virus. So that's a little scary because they are actually the same virus, and you're looking at 3 different areas where the virus is being transmitted. So some of the prevention that we've known is to be able to reduce the transmission, because when you find out what the mode of transmission is, that's how you can go into your different prevention methods. So looking for primary prevention for between animal and human, between bat and human, as well as human to human. And some of the other strategies that were produced from this case was weather protective, personal protective equipment, and at the same time doing this bamboo skirt, which was actually putting it around where they were going to drill the hole, and that would protect it from the bats coming in to being able to lick the sweet palm date sap. So a little interesting. It was the first case was actually what was being presented or portrayed off of the movie Contagion. This actually is something else, but it's different geography, as you can tell, but it's still the virus. When they went through and they found the sequencing, it was still the same virus. The final part is a revision of a case study. Now that you've already heard one of the presentations by Dr. Ferris Iglesias about chikungunya actually in the country, but I actually have been studying chikungunya since it started coming out in the Caribbean, because I was taking a public health surveillance class that required me to actually look at chikungunya. So I wanted to bring that today because I thought it was very interesting about the transmission that you may not have heard, because it requires a little bit of research on O&Med, which I'm not sure if you use O&Med at all. It's very informative about cases that come across. But chikungunya, as we all know, it came from a specific geographic region, and it had limited transmission in the last couple of decades, but it's just recently, within the last 10 years, that it started becoming more prevalent in Southeast Asia, which is where it's originally from. So you can see some of these countries in 2004 where you had different cases that were actually 500,000 cases were discovered in this 2-year period. And mostly obviously from Indonesia and from Southeast Asia, and then different travelers that would come back to the Western Hemisphere, so those in Europe as well as North America. So this is where these 2 years, the 2-year time frame that I was talking about, 2004 to 2006, this is where many, many cases were found. Dr. Ferris Iglesias did talk about the island of Reunion, which is there right east of Madagascar. But this is the area where it would normally come from, and significant number of cases. When we go a little bit further in the next few years, we find that it still stays there, but then you have an expansion of the geography to where it was. So now we're expanding a little bit toward Africa, and also a little bit toward Southeast Asia, expanding the geographic distribution. So here with some of the imported cases. So the red line is actually the geographic distribution of the Aedes aegypti, which is Aedes aegypti and albopictus are ones that are associated with chikungunya, that Aedes aegypti is more what we're associating it with, because it's also with dengue fever. These geographic areas with the red line has expanded from what it has been over the years. So Aedes aegypti is existent in all of these areas. And that the purple you can see are the imported cases that have been shown. But there has been an introduction into about 19 countries, and currently the statistics say it's in 33 countries of the America region. So CHIKV, or chikungunya, has come with international travel, and so until December 2013, there were no cases known to international travel that would cause local transmission in the Americas. So as you can see some of these numbers, these are the travelers that are returning to the US, as well as travelers returning to the French Caribbean nations of Guadeloupe, Martinique, and Guyana. So it's starting here, at least you can see there's a significant number of travel cases. But that's when it happened in December 2013, as we also showed in the last presentation, that this is the first local transmission, and this was until January 9th of this current year, the different confirmed or probable cases of CHIKV, Saint Martin, Martinique, Saint Bartholomew, Guadeloupe, and then French Guiana. So we're increasing in numbers that have not been seen. This was the same time frame as I mentioned, January 6th. So you can see right where the Caribbean areas are. So it is starting, and it is recognizing that there was local transmission, at least in those Eastern Caribbean nations. Going a little bit more in focus now, which these areas, as you see, were not colored in. And now they are, being that there is reported local transmission as of last week, August 12th. So you can see what is colored was not colored before. And they estimate about 33 different countries now have reported cases. So that's obviously something we have been seeing. Those are a little bit more the statistics component than the theory. But how can we actually apply this One Health? So we've been talking about environmental health. We've been talking now about different cases, which actually includes animal health and its connection and its link to human health. So how can we actually apply this to our everyday homework and our role in medicine as well as in public health? So one of the things to consider is looking at collaborations of One Health, being that it does require a dedicated team, because these are complex problems that we need to be able to solve, both domestic public health and global health, to be able to work together, because one discipline can no longer solve these problems. They are very, very complex. And at the same time, all that in order to advance our knowledge, because we are obviously studying one discipline, we are studying medicine, and at the same time public health, since they go hand in hand. But there are other areas that we can join different professional organizations and be able to, that support the concept of One Health. There's a lot more literature out. There's a lot more publications that are coming out on One Health in different disciplines, and it's where that you all can be able to apport from your field of medicine into the whole concept of science and One Health. To be able to know and to, as they say here, comer los libros, right? As a medical student, you're going to be eating books a lot. So that's how you can learn from the courses in public health and epidemiology. So in your classes, because I personally know the professors here in those courses, they're very strict and they're very knowledgeable in their areas here at O&M. In other schools as well, you have different physicians who have significant training in the field for public health, that you can learn from them and learn different strategies that they have used in the clinic. And also from your own colleagues that have spent a significant amount of time at UNAPS, such as our colleagues Maria and Catherine, that they have different strategies they have used when they've taken care of patients during their one-year pasantía. Another thing to keep in mind is that with these changes in the environment, as well as the behaviors, human behaviors, how we are not static, we are dynamic, we move around every day, that we can look at that impact of different emerging diseases, and that might be endemic or that might actually be emerging, that might be now here to stay as endemic. There's a different connection also between the classroom and the clinic, which is something to keep into mind. In your classroom, a lot of times there should be a not forced, a very open discussion. Everyone should be able to bring ideas to the table like you've all been bringing to me today. And so those are areas that you can be able to analyze different clinical cases differently, whether they are descriptive, whether they are laboratory, whether they are very, very basic, because a lot of the concepts with problem-based learning is you have a very vague case, but then you have to be able to bring up different ideas that will present to the whole picture for your patient. And those are some ideas to be able to incorporate them into key concepts for public health. And then in the clinic, some different things for you to look at is the daily life of your patient. So when you're in front, or you're doing your mock interviews, or you actually have your patient in front of you, you need to know what is their daily routine, what are some of their exposures. They may not come out in just asking, how are you today, or where do you live? So you might have to ask, well, what does their house actually look like? They may say that it's block, but they may not fail to mention that there is no cement on the ground. They may say it's ground, or they may say that it rains a lot and there's a lot of water in the house. So there's different things that someone might not bring up, but it is significant for someone who may or may not be wearing shoes, for example. So those are things to bring when we look at diseases that are both endemic as well as emerging. Another thing to recognize is actually your knowledge about risk factors. So it's not just knowing that someone who has hypertension might be more predisposed to having myocardial infarction, right? Being a risk factor. No, there's a lot more to that. Just look here at obesity, which is a graphic I made for an article. Just looking at obesity, which as we consider as a risk factor, being overweight, what is your body mass index, for example, as some sort of factor, although not 100% accurate to identifying because there are many variables. But when you look at behavioral, social, metabolic, physiologic, genetic, and cultural, all of those play a role into obesity. So think of your diseases as such, where you can look at the different risk factors between those. And looking at how you'd be able to integrate both models. So we've talked a lot about this One Health and looking about how you can bring together the medical model as well as the public health model. So looking at diagnosis and treatment to making a healthy individual, but at the same time looking at different these risk factors and prevention when you look for those interventions that can potentially making a healthy community. So that everyone, because individuals live in a community, and so everyone should integrate those models. Finally, the utilization of some of the prevention strategies. So looking at being informed on those new epidemic and emerging diseases. So right now, that's the one thing that everyone seems to be talking about. The most common question, I said that I was not feeling good. The common question I get asked is, do my hands or my feet hurt? So, because they think it might be chikungunya, that's the first questions out of their mouth. Not if, if I'm vomiting, if I have nausea, nothing. It's if my hands or feet hurt, because that's the most common right now that is being transmitted. Also looking at different methods of transmission. So something like we never before really considered the bat except potentially rabies, right? Well, now we're looking at the bat when we look at MERS. We're looking at the bat when we look at Nipah. So there are different modes of transmission. So definitely start thinking outside the box. And then also knowing different types of prevention strategies that might be related not just to the typical everyday life, but also to those that might come in some sort of conflict scenario, where you might have individuals like refugees living in a very closed area, a very overpopulated area, or even post-disaster when you're looking at different types of natural disasters and how they might play a role in what your injuries may be. And finally, know the different levels of prevention. I know you've all had this. This should be knocked in your head when looking at primary, secondary, and tertiary. So when you look at primary, looking at those what are those risk factors for those who may be predisposed or not. Those with secondary, so those that may be asymptomatic but actually have disease pathogenesis. And that those who already have pathogenesis and you want to avoid any future complications. When you look at primary prevention, there are individuals who are going to have a predisposition, for example, although because we're in the health environment, we may be predisposed to accidental needle injuries. So we should make sure we're vaccinated, for example, with hepatitis B. So that's where we would play in certain vaccinations, being that we would be more susceptible occupation-wise. And at the same time, looking at secondary prevention and any sort of screening or subsequent treatment to prevent further development of the disease. And then looking here at those who are symptomatic in order to reduce any chance of further complications. So what are some ways that we can actually disseminate this message for some of our community members? So we're looking at the environment, we're looking at animal health, and we're looking at human health. So how can we actually play that into a public health scenario? Because as a physician, you are going to be that voice for health for your patients. So here are some that actually I've come across here taking pictures. This is for tuberculosis. At least this message of more than 15 days is the message that the Ministry of Public Health has been promoting. So 15 days with a cough, make sure that you can go to the clinic and get treated. That's one of the messages that's been coming across in a very visual pictorial. Another, which is in the Ministry of Public Health, is looking at this in order for Aedes aegypti, that it is a mosquito that works during the day and it's highlighted. So that individuals, a common community member who has no other training can look, these are some of the things that I need to be concerned about. And at the same time, at one of our hospitals in the northern part of the country, they actually put it on a truck. So looking at zero dengue, zero mosquito breeding sites so that there will not be. So there's different modes of transmission. So one's actually on a wall, one's a pamphlet, and one's actually mobile. Some other ideas that, some other health promotional materials that have been had that I've been taking pictures of is looking for rabies, since epidemiology is looking also at, for their anti-rabies campaign, looking at both bats as well as actually vaccinating their pets. So those are different ways on how you can bring the information to the community, the target community that you want. This is also something that is on the web page of the Ministry of Public Health of the Dominican Republic. You can see that this is actually the one thing that you can't help but see it when you turn on the web page. So it's another way, especially when we're talking about e-health, a way to be able to interact with your community members. And at the same time, I have seen this posted in different areas like colmados, because they're very common for people to go buy different things or so. And a final way to look at it is actually putting it in print in a comic, because here everyone reads the newspaper, and it is I'm very impressed that that is a very significant mode of health promotion, and they even put that in here. So this is even talking about the new virus that was coming across, but they have people talking about chikungunya in a comic form. The final little bit is I just want to talk about a couple of the challenges that might be faced. Obviously, medical school is a challenge in itself to finish, and then the formation after that is a significant challenge as well. So there are different challenges you can imagine with trying to incorporate One Health into practice, but it is not impossible, as medical school is not impossible. So some of them, there are complex problems. So as you've seen, think of that you were during the initial epidemic of Nipah virus, what would you have done? It's not impossible. You would do your investigation to be able to come across with what are some of the solutions that are able to keep moving forward, but you have to work in groups, because although the physicians see the patients, they did not see the pigs and near the bats. So the idea also of accepting that One Health is a concept that will require multidisciplinary work. And then teamwork is something that is very challenging between disciplines, but it is something that can embrace this One Health component and be able to work together and learn from each other, and being that as a requisite to be in medical education. So that's about the end that I have of that topic, but since I've been here for a month, I did want to give some sort of appreciation to first of you all for listening to this speech. I hope that you have all learned a little bit more about One Health. It's just a little blurb, but I did come from the Southeastern National Tuberculosis Center in Gainesville, Florida, which is where I'm a research assistant. And I've had support from them as well as from the National TB program here in the Dominican Republic with Dr. Belkis Marcelino. I obviously have the support from two institutions. One would be my home institution of the University of Florida with my advisors, as well as O&Med, School of Medicine, with my advisor, Dr. Perez-Ten, who has been amazing, as well as everyone at this institution, including Anna and Karina, who have helped a lot. So in making this, I also have been here doing some different work, which if anyone is interested in particular with tuberculosis or doing hospital pilot studies, I can talk to you a little bit more about that. I was been doing my work at 2 different hospitals, which have been very exhausting and at the same time very exciting. I've learned a lot in 2 different cities, but it definitely I have definitely sweat a lot. At these 2 different hospitals, Morgan, as well as Cabral Ibáez, which is in Santiago. And then finally, I did want to thank ODM, because they have been very supportive in not only traveling from La Vega to come here to hear this presentation, but also the idea that ODM can actually bring to medical school, and also the same thing with public health, being that everyone is from a different university and from a different area, being that the medical schools are in 5 different cities in the Dominican Republic. So thank you.
Okay, so it's time for questions, comments. Questions? Buena, che. So, quiet.
Thank you for contributing.
Thank you for the presentation.
That's all I have to say about that.
I mean, everything was explained so perfectly, so.
That's a really good sign.
The only question I would have is, how would, as far as One Health and its applications here, how would I be able to follow the progress of it?
That's a good question. We could start a group with One Health to have discussion. That's what we've done at my university is we have started a One Health group, a student group, where we can talk. And actually the individuals who are in the student group are from medical geography to us in public health, veterinary medicine, anthropology, even Latin American studies, I mean, all across campus. So, I mean, you know how UF is. It's a very big university, and basically we're trying to target people from every different department. You can do it very easily here, and I think part of that, since Dr. Guerra works with a lot of the clinical cases, that there might be something that we can start incorporating with some One Health ideas. But definitely they'd be part of something looking at clinical cases and implementing those different areas. So. Thank you.
Just a couple of questions, Helena. Don't go. Please come. It was very easy. You know, you have an easy audience. So first, well, I hope that you see, you know, that you have also evidence and try to come with the evidence in One Health. For example, you see that Dr. Chapman included in the slides two different type of study, right? The case control studies and the cohort studies that you already study in your classes. Okay, so I like very much, you know, the way that you not only do the presentation, but also, you know, the sequence. At the same time, it looks like, you know, that there is some similarities between One Health and human security. Do you want to talk about that? Because I know that you were working with a person, you know, in the human security issues. So probably you want to discuss, you know, or probably to relate or to see some similarities about One Health and human security. Yeah, sure. Come.
Well, a little bit about what I could talk about with that is that, especially, not maybe a little bit in relation to what we have been writing. Know that One Health, especially I think in some of the areas when we look at social medicine, so when we look at the different social factors, they all play a role into human security, in particular with the different types of security. So when you look at economic security, when you look at different health and safety, what's the condition? I mean, we did talk about post-conflict migration. All those areas I see that they are areas that really can propagate disease. And so for that reason, you need to see what are those other risk factors that can be portrayed, such as animal involvement. So in human security, there's a lot of stuff that I have not read about the inclusion of animals. However, when people migrate, a lot of people bring animals. And so no one checks that along through. That's kind of where I see a little bit of a connection.
Sure. Sounds different concept. I mean, in some way, you know, they are related. Let me just, you know, point it out that probably, you know, the audience can perceive, you know, that One Health is just for Malaysia or for Indonesia, because, you know, these are the diseases that you presented and discussed, you know, in your presentation. But it is a way to not just to present the importance of One Health, but also that diseases are not occur at random. Okay, that diseases, you know, are most likely to occur in populations and vulnerable populations. So One Health could be, you know, a very nice concept to apply not only in underdeveloped but also in developed countries. You know, I love the idea, and I don't want to put in the spot, Manuel Che. But Manuel, how do you think One Health, could be applied, for example, in the ICU that you have been working?
One Health, how we
Yeah.
apply it?
Mhm.
I guess that would be, I would have to, before answering that, I would have to ask first a question,
Mhm.
which would be, does One Health usually apply an infectious model to its thinking, in the sense that usually when you see cases for One Health, you usually think there's a cause, that has an infectious cause. Is there a way to connect environment, animals, and humans without an infectious cause underlying?
I will answer that. I think most of the focus of One Health is actually with infectious causes. I'm trying to find some that are with chronic, but a lot of it is with infectious.
Well, I know, why he asked you, that type of question, because the paradigm is like a new paradigm, not only One Health, human security, but also we were working, Manuel and myself, in a proposal that will, with good luck, we will be, supported by an international institution. But again, do you remember, that we were trying to include a musical therapy in the ICU, let's say, system in the Dominican Republic? And how do you think, this One Health concept can apply in this type of proposal?
Well, maybe in the sense that One Health takes into account the environment, and we must take into account that the environment plays a big role into our lives. And part of the environment is the noise that happen in intensive care unit, as well as also we must take into account what is music and how it plays an integral part in our lives, and how can we mix these two together and have better outcomes for patients. And then what preliminary data has shown is that music interventions do have better outcomes. Now, studies have been limited to sedation requirements and anxiety levels. But taking into account the other data that we have on studies on music and how it plays into our growth and our personal development, how can we put that into an intensive care unit and really critically ill patient?
It was an experimental study, or was a quasi-experimental study?
It's experimental.
Yeah, very good.
But I think I have another example which is very interesting. I don't know if here we have cases in the Dominican Republic. It's called Kawasaki disease, mucocutaneous lymph node syndrome or disease. Does anyone know the cause? There is no cause. You usually think immunological. Well, this is where you make bridges between epidemiologists, demographers, clinicians. So there's this study. It's actually not a cohort, not a case control. It's a mathematical study. And what they did was they proved that what caused Kawasaki was the wind. Now, this may seem very simple, but actually what they prove is that they took all the cases of Kawasaki. Because usually, just a little bit of background, Kawasaki is a disease that was first discovered in Asia, Japan, and then after it was described by the namesake Kawasaki, most cases were being discovered elsewhere in the world, but there were still cases. And how would you have this, what is the connection between Asia and, for example, Dominican Republic? That we have several cases here in the Dominican Republic and as well as the United States. So what they did is they did a mathematical model trying to amount what were the common denominator. And what they found was a wave of wind that happens, and here's a connection to One Health, the environment we have, then we have the humans, and then what they had was there were spores from fungi, and they found that those patients that had this specific fungi also had Kawasaki. So I guess that would be interesting now. The next step is to actually...
Yeah, well, this is why,
But I think it's a great example to how you can take these different backgrounds and how you can collaborate and have an interesting idea and what can you do about it.
Yeah, and that was the reason, that I asked you, because I think the One Health concept, as the same as the human security concept, could be applied to any single disease or to any single system that you want to study. You see, if you see, for example, your proposal about the musical therapy, are you going to be alone or are you going to be with other people doing this kind of proposal? So you need a musical therapist, you need an epidemiologist, you need an ICU person, but also you need nurses, okay, and researchers. So that's the way, I think this is the beauty of this new paradigm, that you bring with this concept of that you are not alone in medicine, that you need people, that you need more, let's say, actors involved, and try to, share experiences and try to improve the quality of health, of the population. There is any more comments in the audience?
I have a question for you. From time to time, public health has new main strategies. First was alma mater resolution. Then there was Millennium Development Goals. Do you think that One Health should be the next strategy?
It could be. The Millennium Development Goals, because they're done for a certain period of time to have specific outcomes after. Whether you're actually reaching the goals by the time 2015 comes, and then to make new goals for the next, 5 years. I think One Health, it may be a little complicated to make some sort of goals, but I think maybe it could be used as a tool or one of the strategies to be able to incorporate that with some, because one of the Millennium Development Goals, among all of them, one has to do with nutrition. Another one has to do obviously with infectious diseases, such as malaria, TB, HIV. So I think maybe on some of the goals, not all of them, because one of them has to do with the environment, also one of environmental sustainability. So if you can go and maybe implement that with those, post 2015 development plans, I think it would be advantageous.
That was a beautiful question. I think it is a matter also to think in global health. Okay, one of the assignments that I would like to put, in the second goal is how they are going to relate, One Health and the Ebola disease, for example. Now that we have, all these, let's say, scary announcements in the newspaper and in television, how do we apply, One Health to the concept of preventing or trying to deal with Ebola in the Dominican Republic? You see, it's a global health concept. I think this is the beauty of see, the health, that something that can happen or happen, in the Dominican Republic could happen in all part of the world or in any part of the world. You see, so I think we need to think very seriously about the concept of One Health in the near future. Probably we need to include that kind of things in the development, the Millennium Development Goals. That could be another name, in the near future, because that's the beauty of the policies and global health in our countries. So if there is no more question, let's give an applause to Dr. Chapman. Thank you so very much. I know that Pilot Bob and Mama Chapman will be very proud of you. Yeah, definitely. Then we will have a toast, or vamos a tener un brindis en la quinta planta. Vamos a tener un brindis en la quinta planta. Bueno, de ahora en adelante ya tú conduces esto, que tú eres que sabes de las cosas. Vamos a despedir a Chapman y ya saben que vamos allá arriba a compartir con ellos. ¿Okay? Sí.
Yo voy a mirar a los doctores. Hagamos entrega de un presente, un regalo por la participación suya.
¿Qué más?
Y también, como dice el doctor, vamos a terminar este evento con una compartir social, la planta, la cafetería, la cámara.
Entonces, hagamos.
Gracias.